So, we are going to chat to you about a piece of work that we've been looking into. We're trying to understand the potential impact of the presence of families at cardiac arrest events. Ines.
So it's quite well known. There's plenty of research surrounding family presence already. We've got some from the Nursing Times, we've got some from the paramedic, we've got within medicine, and then we've also got the guidelines from the Reasons Council themselves.
So we are following on this literature where we're interested to see is, can we pick up any signals of what is happening when families are present at our resuscitation events? So what did we do? Well, we looked at some cases that were initially a bit undiscovered to us. And I'm clicking the green button, but it's not moving. Wonderful. So we looked at some kind of unique cases where our colleagues had ticked a box on our form that says it was the recognition of life extinct. So they didn't think this patient was survivable, but they also clicked that they did 20 minutes of ALS. So two boxes that don't often go together, that we thought something interesting would be happening at scene. So Ines was one of 3 students, and these 3 students looked through initially about 900 incidents. It was about 550 after duplicates were removed. The 3 students painstakingly looked through about 70,000 words. We locked them in a cupboard for five weeks. And of all the themes that we found that the mentioning of family was present in about 40% of cases. So that in the written descriptions of the real case notes that our paramedics wrote over the course of a year, family presence felt like it was important.
So for those that maybe aren't quite aware of the SCAS format, they use Therapace. Over on your left-hand side, we've got the out-of-hospital cardiac arrest button. Within this section, there is an area for roll, so recognition of life extinct, and then there's another section specifically for when 20 minutes of ALS have been carried out. So in the cases that we looked at, both of these buttons were clicked, which typically we found pretty interesting.
So, what did we find? What are our colleagues writing for these patients? This is verbatim, and if there's any identifiable information, we've taken that out. So somebody's saying, okay, we've been called to an 87-year-old lady, slumped on the side of the chair, seen approximately 90 minutes ago, but if you think a distressed family member, that's difficult to gauge. And some signs that this patient maybe is indeed already dead, that there's some post-mortem staining here. And just a little nod that family presence was there, something was going on. So not a strong signal, just at this stage, okay, the family was present. But Ines will say things started to become a bit more stronger.
So another case we had a 64-year-old female who was last seen about 1:30. Partner couldn't wake her at 5:30. Post-mortem was staining was noted, as well as rigor, and rigor mortis in the jaw. CPR was continued, and then additionally the crew had stated the son was downstairs in the flat who had initially commenced CPR, and the family had been distressed throughout the incident.
So again, this time just a little bit more emphasis on the family, a little bit more that the family presence is maybe a factor in there.
Another case we found was another male patient found unresponsive by his wife. On arrival, the patient was cold, there was staining to the groin, the legs, the pupils were fixed and dilated, all signs that were potentially incompatible with life. However, again, the crew mentioned they continued CPR in view of the wife's attempts.
So now it's becoming more explicit. We're finding more evidence that actually our crews are saying to us, I'm continuing this in some way to manage this difficult family dynamic. And potentially the most explicit, the most obvious one.
So this patient had history of cancer. There was no DNA CPR in place. ALS was commenced, PEA throughout. There was enough clinical evidence to carry out a confirmation of death. However, due to family expectations and now being in the ambulance in a public place, decision was made to continue resuscitation efforts despite high likelihood of futility.
So, take-home messages. It can be uncomfortable reading, and is the take-home message simply family presence, sometimes it's really bad? Is it, well, we're reading that quite explicitly in some situations, family presence is prolonged resuscitation, and is it as simple as there's some relationship between family presence and futile resuscitation. I'd say hold in your mind, no, it's too simple. And I think as Shorty has chatted about earlier is the impact of families being there in some moments is going to be entirely beneficial for them and their well-being psychologically, for future anxiety and stress that they may feel. Sometimes that's going to help the family. But in some situations, it may adversely affect, that's the wrong word, it may affect what's happening at scene and how confident our clinicians are to pronounce a death when it's suitable. So in a way, our presentation today is to say, take some thoughts away with you. We don't have all the answers. It's a complex area. And we just want to leave you with this thought and chat about it amongst yourself. And if and when these cases come up, chat with Shorty, chat with Donald, chat with the cardiac arrest team to understand the potential effect and the learning from this. So just want to say a big thank you to Ines, who's come down from Inverness to do our first presentation at a conference. And you're going to present in the College of Paramedics. So thanks for listening.